So I think it's a good transition point to talk about what do you think is the biggest unmet needs in patients with sarcoma. And again, I know this is a broad statement, and I'm sure there are unmet needs for patients with soft tissue sarcomas and then unmet needs for patients with GIST, and we can probably divide it that way and talk about those two patient populations.
Yeah, I do. I agree with you completely. I think there's a fairly long list of unmet needs for our patients that have been affected by soft tissue and bone sarcomas. And one of the unmet needs we discussed earlier is having centralized sarcoma pathology review. There's a wealth of literature showing that an experienced sarcoma pathologist will change the diagnosis 20 to 25% of the time, meaning that there are patients out there who are getting the wrong treatment, getting the wrong surgeries, getting radiation therapy when they shouldn't. And so I think that's really a huge unmet need, is being able to get centralized pathology review by sarcoma expert pathologists. Another unmet need remains treatment. We need more, we need more effective therapies. We have 175 different sarcoma types, and angiosarcoma is as different from liposarcoma as breast cancer is from colon cancer.
Until not many years ago, we were treating, and even now, we treat most of them sometimes the same, but we do realize that they're so different. So yes, I think the challenge is, being a rare disease, it's difficult to study each subtype separately, but what we have seen over the past few years as a sarcoma community, when we come together, you can actually run and complete trials in specific subtypes and actually show a response, whereas when you put all of them together, the efficacy signal gets diluted, which is why we have lost so much time in actually getting effective therapies into the market. So
yeah, a great example is avapritinib.
Yes.
Its recent approval by the FDA for the use of PDGFR D842V mutant GIST. Right. So this is maybe 5% of GIST patients. Yeah. So that's a very small number of people. That might be 250, 300 new cases diagnosed each year in the United States. Yet we were able to come together, do a clinical trial, show an almost 90% response rate in this subset.
That's amazing. And well, if it was last year, we would be calling that as an unmet need, because we didn't have anything for PDGFR D842V patients, and now we do. So I think, you're right. I think really looking at subtypes and understanding their molecular, background a little better, and then choosing treatments accordingly, I think is hopefully going to help us move the needle forward a little bit more and help us with these patients.
So I think that another unmet need in the field of sarcoma, bone and soft tissue sarcomas, I think another large unmet need is the use of immunotherapy. We've seen immunotherapy, we've seen the successes in melanoma, in lung cancer, in a number of different cancers where it's made a huge impact. And I feel like in sarcoma, maybe we're a little behind there. We've been ahead with the targeted therapies, but I think we're a little behind the other solid tumors in terms of immunotherapy. What are your thoughts about opportunities?
Yeah, no, I mean, again, there is a huge opportunity there. But yes, we're behind, even though I think the first case of immunotherapy in tumors was described in a sarcoma patient way back when, right?
True.
The Coley's toxin was a sarcoma patient. But we've done a couple of trials. The SARC-28 trial reported on pembrolizumab, and we saw activity in UPS and some D. diff liposarcoma patients. And then we had a nivolumab versus nivolumab plus ipilimumab study reported, again showing, but what's become clear is, again, we knew this, all subtypes are not the same. They don't respond the same. And what's challenging is we still don't have, we know the layout of the patients who respond to immunotherapy now, but we don't have a good way of picking out those patients up front who are going to respond to immunotherapy. But we did make some progress, I think, through the trials that have been published and trials ongoing. There's some subtypes that have emerged as clear winners, even though without a good rationale for why it would probably work, as alveolar soft part sarcoma, again, a very rare sarcoma subtype with no standard treatment options. Chemotherapy does not work for ASPS, and that seemed to be the winner for immunotherapy. You know, more than 50% response. It was reported with the axitinib plus pembrolizumab study. We ran a study with durvalumab and tremelimumab, and we saw the same thing, more than 50% response in ASPS, and very durable and long responses. Again, this is a subtype which is translocation driven. It's a very,
low mutation
burden, but these patients do have immune infiltrate, and that increases on therapy, and they have beautiful responses. So still a lot more to be researched, and I think we can learn a lot from that subtype. But for the other subtypes, I think the data is still emerging. I think we need to select our patients, better, and we still have to keep researching. Maybe it's not just the anti-PD-L1 and anti-CTLA-4, and we have to diversify into other, inhibitors to treat. The other success we've had with immunotherapy is actually with tumor testis antigen-directed therapy with the T cells, adoptive T cells. Again, synovial sarcoma and myxoid round cell liposarcoma have a very high expression of NY-ESO-1. Again, a tumor testis antigen that is not expressed in your normal cells. And TCR-based technology is now published and shown to have great responses. I think it's, again, a niche field, and we still have more to learn how to maintain these responses long term. But I think, slowly we're making progress. But yes, we're far behind the other cancer types, but I think we just have to keep working and keep completing our clinical trials that are ongoing.
Yeah, I think we're catching up. I think that another area is the angiosarcoma.
Angiosarcoma, yes. So, again, that's very interesting because, when you look at angiosarcoma, it's the cutaneous angiosarcomas that respond.
Exactly.
And it's, and not all the primary breast angiosarcomas, but it's the cutaneous, mostly head and neck, sometimes radiation-associated ones that respond to immunotherapy. And there seems to be something to do with either, a high tumor mutational burden or the UV signature that's probably in place in these cutaneous angiosarcomas that leads to this high response rate with checkpoint inhibitors. So again, yes, that's another
70% response rate in one study.
Yes, that's pretty interesting. And then again, there's recently published data with the TVEC, which is intratumoral injection, along with nivolumab, again showing responses.
Looks promising too.
Looks promising too. Yeah. So more to come with the immunotherapy in the future.